Hello, I'm Raymond Danks, representing UCL, and today I'm going to be discussing our paper, Automating Periodontal Bone Loss Measurement via Dental Landmark Localization. Okay, so firstly, I'm going to discuss periodontal disease and how that relates to periodontal bone loss. Periodontal disease is a microbially associated inflammation, and it's currently the sixth most common disease worldwide, and periodontal bone loss indicates severe periodontal disease and is defined as the degradation of the bone surrounding the tooth. You can see this on the right-hand image here. You can see the bone loss as well as the inflammation too. The detection method that we're going to focus on in this project is radiographic assessment. There are other ways to detect periodontal bone loss, such as pocket probing, but radiographic assessment is the best way for automation, in our opinion. The definition of periodontal bone loss is the ratio of tooth supported by the bone, and that's what we intend to calculate with our method. The consequence of this of periodontal disease and the motivation behind our work is that periodontal disease is currently the leading cause of adult tooth loss, and the treatment can range from antibiotics to periodontal surgery. So it's very important to be able to define how severe the periodontal bone loss is and how severe the periodontal disease is to inform an interventional decision. Okay, so radiographic assessment, why do we need to automate this? There are two main types of radiographs used. There's panoramic and periapical, as you can see. The panoramic gives a more holistic viewpoint of the entire mouth, whereas the periapical looks at a very focused image of 2 to 4 teeth, and throughout the literature has a superior accuracy to the panoramic radiograph for this method. The limitation of radiographic assessment currently is that it exhibits substantial inter-observer error. If two clinicians are to look at the same radiograph, they could have two different decisions of what periodontal bone loss percentage they see. The solution to this is a computer-assisted diagnosis, which amalgamates multi-expert assessment and multi-expert labels to give an objective and consistently accurate measure of periodontal bone loss, and it's hoped that this will be able to detect small changes in periodontal bone loss to track the progression of the disease and to hopefully give interventional preventative measures. So we decided to go for the periapical radiograph as it's historically more accurate, but also the research in this domain, especially for periapical radiographs, is far less than panoramic, and therefore this domain is limited, and we would like to fill that gap. So quickly, we're going to go through the contributions all through the presentation. But firstly, our main contributions are that we're the first paper to explore deep learning for landmark localization on periapical radiographs. We introduce a novel data augmentation technique called Interstitial Spatial MixUp, and we introduce a complete end-to-end clinical pipeline, which we quantitatively and qualitatively assess on numerous root morphologies, which we find emulates current inter-observer error even at this stage. So, in measuring periodontal bone loss, you can see a diagram here. We discussed that the definition of periodontal bone loss is the ratio of the tooth supported by the bone with the length of the tooth. And this is measured, it's recommended clinically to be measured between the landmark's apex, bone level, which is the intersection between the tooth and the bone, and the CEJ, which is the cemento-enamel junction. And this is why we've selected for a landmark localization technique, so as to conform to this clinical method. As you can see on the left here, we have a double-rooted tooth, and this has 8 landmarks. But throughout this project, we assess single, double, and triple-rooted teeth, which all have differing landmarks, which is shown on the screen now. Okay, so the clinical categorization of periodontal bone loss. Periodontal bone loss is usually put into 4 severity groups, and these inform interventional decisions, as is seen on screen now. These are examples from our own data set showing single teeth which point downwards, showing the 4 different stages or examples of the 4 different stages of periodontal bone loss. This is our proposed solution. This is going to act as a contents for the rest of the presentation, but I'm going to break it down into a few different key points. The single tooth detection here from the full periapical radiograph, we model with exact solution. This is a more fruitful area of research, and it's been discussed many times. And also it's a less complex problem than the landmark localization, especially seeing as we're not segmenting the actual tooth. And so we've taken that as a given and we've modeled it exactly. We use a symmetric hourglass for localizing our landmarks, and we discuss this network in depth in the next slide. We have a novel data augmentation method, ISM, which is discussed throughout the presentation. However, you see an example here. We pre-train our network with apex landmarks just to establish the region of interest and make sure that the network is identifying the correct tooth and not getting distracted by the adjacent teeth, as we're not segmenting the teeth, like I say. And finally, we have our post-processing, which calculates the periodontal bone loss percentage and a respective severity stage based on these localized landmarks. Okay, this is the network we're using. It's a fully convolutional network. It's an hourglass network that's been adjusted from the cited paper. The cited paper used an asymmetric hourglass network, but we've adjusted it to be symmetric on each side, which conforms more closely to previous literature in body pose estimation, specifically for stacked hourglass and single hourglasses, which should be symmetric. We've used a hierarchical multi-scale parallel residual block, which eases computational constraints when compared to the bottleneck residual block. It's important that each root morphology, as we've discussed, has a different number of landmarks, and therefore it has its own separate network, which impacts on the results later. Interstitial spatial mix-up. This is just showing the method for it. You have two different sized images. You put the smaller image into the center of the larger image, and they're interpolated, the larger image with the black space and the smaller image, and the smaller image entirely with the larger image based on a random gamma, and the landmarks are interpolated in the same method with the same gamma. The hypothesis behind this is that the mix-up data augmentation has been shown to work for landmark localization in itself, and this hopefully ISM will create a more robust confidence map of this, showing that the predictions based on the larger image, which is interpolated with black space, and the smaller image, which could be interpolated with a busy image, is interpolated with the other image. These should have the same weighting rather than getting distracted by these extraneous variables, and they should come to the same conclusion. The methodology used to calculate PBL, the big equation here, and we've got a key on the right-hand side, just in case you've forgotten the acronyms. The big equation pretty much describes that we find the ratio of tooth supported by bone with the length of the tooth on each the left and the right-hand side of the tooth. This does mean that we ignore the central periodontal bone loss, which is especially prevalent in more severe bone loss cases, but this is an avenue of research that we hope to go into in the future. And the severity stage is predicted from this periodontal bone loss percentage. Periodontal bone loss and severity stage is compared to our clinician's diagnosis through two different ways. So we have clinicians label landmarks, and we calculate the periodontal bone loss using the same equation. And also we get clinicians to directly estimate what they would say the periodontal bone loss percentages of an entire periapical radiograph, which includes 2 to 4 teeth, which is more aligned to how it would be done in clinical practice. Okay, so our data set description, as you can see, it's mainly weighted towards single rooted teeth, and decreases data set sizes respectively for double and triple root teeth. Our takeaway points for the data set are there are 63 patient cases with 340 periapical radiographs, and these are on all of our landmarks, and our periodontal bone loss percentages are labeled by 2 postgraduate specialist trainee labelers, which becomes important for our results. So our results here, the quantitative results anyway, they're shown in the red rectangle, and you can see that when weighted with the data set size, our method outperforms all of the other methods, particularly the competing asymmetric hourglass with our ISM additions, the asymmetric hourglass being the one from the previously cited paper, and the additions being the pre-training, which we've discussed earlier, as well as some pixel normalization. You can see this is mainly because our network performs better on the single rooted teeth, whereas the asymmetric hourglass can perform better on the double and triple rooted teeth. And you can also see that ISM has been compared to mixup for the symmetric hourglass, and it shows improvement upon mixup with the same network and the same additions, although we would of course have to do this for more networks and for larger data set sizes to really robustly confirm this. As you can see, the triple rooted teeth have better landmark localization than the double rooted teeth, which is curious considering they have less than half the data set size, and this is discussed in the next slide. And also it's important to note that all of our additions and our ISM and mix-up all increase the accuracy of our landmark localization, which is as expected. Okay, so our qualitative landmark results, you can see here on the first row, single rooted teeth, on the second row, double, and on the third, triple. You can see that for the single rooted teeth, we have very impressive results. Within 25 pixels are 88.9% of our predictions of the base landmark labels, which is very impressive. We show variance with some radiography conditions, which can be seen on the middle center image, on the bottom center image, sorry. And you can see what we believe to be the reason why the triple rooted teeth localization performs better than the double, even though they're more complex and there's less data. And that's because all the triple rooted teeth align spatially. They point downwards, where compared to the double rooted teeth, which can point in numerous locations. And you can see that the CEJs, particularly on these images, is accurately predicted when compared to some of the other landmarks. So we, like I say, we compared two different clinical measurements based on the pure landmark localization method, which you've seen at the top of this slide. We get a severity stage accuracy of 68.3. And as you can see on the figure on the right, for the lower severity stages, we do pretty accurately agree with the clinician's labels and the calculations from that. But overall, especially with the higher severity stages, we do consistently underestimate the periodontal bone loss. And for the second analysis method in comparison with clinicians, which is clinicians diagnosing from an entire radiograph, we have a severity stage accuracy of 58%. And you can see that most of this is confusion from the central classes, which is the predicted stages of 2 and 3, which don't necessarily line up with the actual stages all the time. And it's important to note that these labels are an estimate by clinicians, and we'll evaluate what this means in this slide. So our performance of 58% when compared to clinicians' initial estimates of entire periapical radiographs. Literature shows that this emulates current inter-observer error, which is very impressive, even though we've got only 2 labelers currently. Our system is essentially acting as an extra clinician in the room, which is very important for interventional decisions and very encouraging for our progress. Interstitial spatial mix-up, like I say, it has been shown to increase accuracy on our network and on our data, but to prove this for more networks and data, it would have to be further evaluated. Our future research, the main take-home points: increasing the size of the data set, improving the data processing, specifically adding in spatial transformation networks to align all the data spatially as it is done in the triple-rooted teeth, and increasing the variety of the cross-labelers. This is very important when it comes to overcoming this inter-observer error, and currently our performance is showing that our network is performing well in this regard and could only increase based on the variety of cross-labelers. Okay, thank you very much for listening, and we'll open for questions.